dear colleagues. My talk will shortly address the use of plasma-derived medicinal products in the trauma setting. In terms of conflict of interest, I have to mention that I am the medical director of Octapharma Benelux. I have no other conflict of interest to declare. This figure, extracted from the recent European guidelines on trauma management, nicely illustrates the link between trauma, shock, endotheliopathy, and traumatic coagulopathy. The figure highlights the central role of systemic endotheliopathy on the complex mechanism leading to severe clinical symptoms associated to trauma. Trauma-associated coagulopathy is a complex evolving phenomenon leading to complex coagulation abnormalities. This coagulopathy is beyond the scope of this presentation, but it's important to know that it can lead to bleeding and/or thrombotic phenotypes. In severe trauma, as shown as this publication from Gando in 2001, an initial bleeding phenotype associated to hyperfibrinolysis switches to a thrombotic phenotype rapidly afterwards. Understanding this moving scene is pivotal for proper patient's management. Trauma is a rapidly evolving process, implying a timely management of shocks through proper fluid resuscitation, but also the management of the endotheliopathy, of the bleeding, and later of multi-organ injury leading to multi-organ failure that are mediated by inflammation and the thrombotic phenotype of the patient. It is difficult to dissociate each of these disorders and to address them separately as they are intricate and sometimes concomitant, but I will concentrate on clinical manifestation that should be considered early in the process. It is during this initial period of time that human plasma could play a significant role by addressing not only the shock, but the other present and future clinical abnormalities. The use of coagulation factors after proper fluid resuscitation and shock control are beyond the scope of this presentation. So my talk will mostly concentrate on fluid resuscitation for shock management, its impact on endothelium and glycocalyx, and the link between the endotheliopathy and coagulopathy and fluid loss. The type of fluid recommended by the recent European guidelines on trauma management includes isotonic crystalloid solution in case of hypotensive bleeding trauma patient and a restricted use of colloids. I'm sure you are familiar with these recommendations and I will not elaborate on them. Recommendation on the timely use of tranexamic acid can be understood, as explained in a preceding slide, by the presence of an initial bleeding phenotype due to hyperfibrinolysis, at least in severe trauma. These guidelines also recommend the initial management of patients with expected massive hemorrhage with FFP or pathogen inactivated FFP. Fluid resuscitation and initial coagulation resuscitation with FFP are, however, frequently concomitant, and it seems difficult to envisage initiating coagulation resuscitation with FFP after successful fluid resuscitation because of the risk of transfusion-related circulatory overload associated to FFP in normal volumic patients. So the question is to know what place human plasma could take in fluid resuscitation. Currently, knowledge and practice can be summarized as follows. Intravenous fluid management of trauma patients is fraught with complex decisions that are often complicated by blood loss, coagulopathy, glycocalyx and endothelium damage, inflammation, and risk of multi-organ injuries that could lead to multi-organ failure. The current guidelines for shock management in the trauma setting recommend the use of crystalloids and the limited use of colloids that are often not efficient in fluid resuscitation in case of endothelium damages, are detrimental to coagulation and induce dilution coagulopathy. Most specialists are currently recommending a limited use of crystalloids and no use of colloids. Recommendation for the concept of massive transfusion suggest plasma, platelet, red blood cells transfusion in a ratio close to 1:1 to achieve adequate tissue perfusion and oxygenation while correcting or preventing coagulopathy as far as possible. Recent publications tend to indicate that the early administration of human plasma has the potential to restore intravascular volume and blood clotting properties efficiently and to correct glycocalyx from shedding and so to limit the subsequent endotheliopathy. As already mentioned, it is clear also that human plasma should be used carefully if target arterial pressure is reached because of risk of transfusion-related circulatory overload. Let me now summarize in one slide the link between endotheliopathy and fluid loss. The revised Starling law summarized in this equation resolves the discrepancies between predicted and measured filtration rate by replacing PI, the interstitial osmotic pressure, by PG, the osmotic pressure in a small protein-free zone between the endothelial glycocalyx and the endothelial cell. This zone is identified as sub-AG space in the left figure. Drying of the small protein-free zone induces shedding of the glycocalyx and injury of the endothelial cell junctions leading to a fluid loss. In this situation, no fluid has colloidal properties anymore as the intracellular junctions are open. So initial fluid losses induce glycocalyx drying and shedding that leads to the opening of endothelial cell junction and consequently to further fluid loss. This is illustrated by the left bottom figure in the setting of sepsis, showing that the described endotheliopathy can also be observed in other settings than trauma. The impact of endotheliopathy on coagulopathy has been nicely illustrated by Pierre Johansen already in 2010. In this figure extracted from his publication, you can see the link between the hemostatic response measured by thromboelastography and the severity of the trauma-induced endotheliopathy. In case of severe trauma, an important hyperfibrinolysis is observed, but in moderate trauma, for example, an hypercoagulopathy is seen. Due to the complexity of the matter, it would take too long to discuss of the different hemostatic phenotypes that can be observed in trauma patients and of the underlying mechanism, but it can be concluded that the observed coagulopathy is related to the severity of the systemic endotheliopathy. So the previous two slides aimed to stress the fact that endothelium damages lead both to fluid loss and coagulopathy, and that endothelium repairing and protection should be taken into consideration during fluid resuscitation. I would like now to review some recent publications that are, I think, relevant to further evaluate the use of human plasma during fluid resuscitation. It is for sure not a proper literature review, and the selection of articles is probably biased, but indeed the intention of this presentation is not to conclude, but to open the debate. In their 2015 publication, Schratt and al. Concluded a fixed dose of FFP transfusion in critically ill patients decreased Syndecan-1 and factor VIII levels, suggesting a stabilized endothelium condition, possibly by increasing AM13, which is capable of cleaving von Willebrand factor. Let us now review in more detail the other publication listed in this slide. In a recent very interesting review, Milford reviews the impact of glycocalyx injury and fluid loss. She stresses that damage to the endothelium glycocalyx term shedding occurs in a number of critical illness, including sepsis and severe trauma, and that the degree of shedding is associated with poor outcomes. She also stressed that it's likely but not proven that protecting and restoring the endothelium glycocalyx in these conditions will improve outcomes, and that there is growing evidence that commonly used resuscitation fluids differ in their ability to protect and restore the endothelium glycocalyx and to modulate endothelial permeability. Finally, she stated that it is therefore important when choosing resuscitation fluids for these patients that clinicians consider factors additional to oncotic properties, including ability to protect and repair the endothelium glycocalyx. In conclusion, the current understanding of the endotheliopathy and glycocalyxopathy associated with trauma suggests that human plasma could be the best current fluid for immediate resuscitation of these patients without compromising coagulation and with a positive impact on glycocalyx and endothelium integrity. The following slide will summarize some publication of clinical data supporting this conclusion. In a post-hoc combined analysis of the Combat and Pampas trial aiming to examine questions that could not be answered by either clinical trial alone, the hypothesis that pre-hospital transport time influences the effects of pre-hospital plasma on the 28-day mortality was tested. Pre-hospital transfusion of 2 units of plasma was compared with crystalloid-based therapy. After adjustment for injury severity, age, and clinical trial cohort, a significant association with pre-hospital transport time was detected. Increased mortality in patients with the standard care group, so meaning the crystalloid-based therapy, was observed when pre-hospital transfer was longer than 20 minutes, while increased mortality was not observed in patients in the pre-hospital plasma group. So these data suggest that pre-hospital FEP transfusion is associated with a survival benefit when transport times are longer than 20 minutes. This supports the recommendation of a limited use of crystalloids and the earliest as possible use of FFP. In the Kamazin et al. Publication presented in this slide, a previous secondary analysis of a prospective observational study in 101 pediatric ICUs, corresponding to a total of 419 patients, is reported. The analysis aimed at determining if the use of single donor plasma compared to solvent detergent-treated plasma was associated with INR correction and ICU mortality reduction in critically ill children. All critically ill children were included into this analysis if they received at least 1 plasma unit during 6 predefined 1-week periods. All children were exclusively transfused with either single donor plasma or solvent detergent treated plasma. FFP group included 357 patients, the SD plasma group 62. There was no difference in the median interquartile range INR reduction between single donor plasma and solvent detergent plasma study groups. ICU mortality was lower in the solvent detergent plasma arm compared to the single donor plasma group. The mortality was respectively 14.5% versus 29.1%. The observed decrease in incidence of mortality in critically ill children, besides same level of INR correction, is suggesting that the observed favorable effect is not coagulation related. The VIPER-OCTA randomized pilot clinical trial, an investigator-initiated single-center blinded randomized clinical trial aimed at comparing the effect of coagulation support with solvent detergent-treated pooled plasma versus standard fresh frozen plasma on glycocalyx and on endothelial injury, bleeding, and transfusion requirements. 57 patients with thoracic aortic dissection were included into the study. As you know, thoracic aortic dissection is an acute critical condition associated with shock-induced endotheliopathy, coagulopathy, massive bleeding, and significant morbidity and mortality. The Stenball and An publication reports that the SD-treated plasma group displayed a significant reduced damage to the endothelium glycocalyx as assessed by CDECN1 plasma levels and reduced endothelial tie junction injury as assessed by SVE cadavrin plasma levels compared to standard FFP. The 30-day mortality was 20.7% in the SD plasma group compared to 25% in the standard FFP group. Bleeding during surgery, 24-hour total transfusion and platelet transfusion volume and goal-directed use of chemostatic were significantly lowered in the SD plasma group. In sum, in this study, the use of SD-treated pooled plasma was shown to reduce glycocalyx and endothelial injury, to reduce bleeding, transfusion and use of premosthetics, and time on ventilator after surgery compared to standard FFP. These observations by the associated reduced amount of danger signal associated to FFP, residual blood cell and cell fragments reduction, lower level of microparticles and cytokine in SD-treated plasma compared to single donor plasma. The following publications point on towards a difference between single plasma and pooled SD plasma that could be explained by the qualitative and quantitative composition of the product. Spinella et al. Show that the difference in cellular microparticle and functional hemostatic parameters measured between plasma products have the potential to affect efficacy and safety. They showed that SD-treated pooled products have reduced residual cells and microparticle counts, but altered thrombin generation kinetic compared to FFP and lyophilized plasma. The clinical relevance of this difference need to be prospectively evaluated in clinically ill patients. Shah and al. Showed that solvent detergent plasma exposure resulted in the lowest cytokine production, suggesting lower immunomodulatory potential. Further work is already needed, according to them, to determine how these in vitro findings may correlate to the bed size. Then al. showed that stored plasma units from trauma center blood banks were highly contaminated with leukocyte and platelets at level more than 15-fold higher titers than sufficient to elicit ex vivo inflammatory responses. In light of paradigm shifts toward the use of more empiric plasma for treatment of hypovolemia, the study suggests that new manufacturing and quality control processes are needed to eliminate previously unrecognized cellular contaminant present in stored plasma products. So the observed clinical differences between single donor and SD-treated pooled plasma can be objectively linked to difference in qualitative and quantitative composition between these two types of product. As said, coagulation management is out of the scope of this presentation. The use of human plasma has an important role to play at the early beginning of the trauma, but further goal-directed coagulation management have to be considered as soon as shock is resolved, thanks to a proper fluid resuscitation. In conclusion, in the setting of trauma, the choice of the fluid used for the initial treatment of shock should be considered, or should consider the impact of the treatment on the endotheliopathy and coagulopathy associated to trauma. In vitro and animal in vivo experiments, as well as recent human clinical trials, point out towards the interest of using human plasma in this setting and its superiority towards colloids and crystalloids. Pooled SD plasma, which is a medicinal product for human use, could be superior to single unit FFP, a labile blood product, thanks to its standardized composition, allowing standardization of protocols, its low contamination by blood cells, cell debris, and cell antigens, decreasing acute anaphylactic reactions, its low content of mediator and inflammation, and the absence of lipids, the absence of HLA and anti-leukocyte antibodies impacting the TRALE risk, and its control risk of transmitting infectious disease. Thank you for your attention.